Yeah, so maybe I'll just start talking. I know people are rolling in. My name is Rafi Avedian. I am orthopedic tumor surgeon at Stanford. Dr. Ginger Holt, who will introduce herself in a few moments, but we want to thank you guys for joining us. We're very lucky to have Dr. Schwartz talk about the history of MSTS today. A brief introduction to this program. We're hoping that through the MSTS Fellowship and Education Committee, we're able to bring our fellows together in this virtual platform to discuss various topics. I know I sent you the email previously to discuss that, but we'll go from things like research, starting a practice, starting a tumor board. We'll do clinical cases, avoiding complications, medical legal issues, a lot of, all the various topics that you encounter in practice that will be specific for tumor, because I know the BOS through the AOS does a fellowship course as well, but everything we talk about will be very specific for oncology practice. We're very open to suggestions. If there's stuff that the fellows want to hear about or have a panel discussion, whether it be about a lecture topic or just even an opportunity for fellows to get together to review cases, we can make that happen. So I'm very excited for this. I'm going to turn it over to Dr. Holtz, and thank you all very much.
Welcome, you guys and gals. We are recording this, so I know Julia had said there were a few people who could not make it to the meeting. Again, this is our first go at this, so we're kind of figuring it out along the way. I want to first thank Deborah and Carrie for putting this together fairly quickly for us. So thank y'all. And Julia, who you guys know, made me promise to show I'm having a bourbon. So this can be, although Dr. Schwartz is wearing a shirt and a tie, keeping it informal and putting your questions up. We'll ask questions as we go. But the idea for this was for you guys to get to see people, meet people that you may not in any other setting get to see or meet, and the ability to hear about things that we don't normally talk about. So Dr. Schwartz is becoming the new historian for the Musculoskeletal Tumor Society. And I have to say I'm in Nashville. I have been with Dr. Schwartz for I don't know how many years. I was here to start as a resident in 1996. I've learned probably everything I know about oncology from him. He finishes his fellowship in Chicago, his residency in Chicago, fellowship at the Mayo Clinic, and then has been here at Vanderbilt since 1987, which is before probably any of us, not me, but we're born even. So the history he has is extraordinary, and I'm very thankful that he would agree to be our lead speaker here to tell you guys all about the history of orthopedic oncology. I don't think you guys have the ability to talk on this webinar, but send questions through the chat as we go. We'll get to them at the end.
All right. Well, thanks, Ginger, Rafi, and MSTS, Carrie and Deborah, for the opportunity to be the first. It's always nice to be the first, especially when you're one of the last and one of the oldest. So I thought I'd present today a little bit of the history of orthopedic oncology, and then how that leads into the formation and the beginnings of the Musculoskeletal Tumor Society. So Mike Simon was the first historian. I learned a lot from Dr. Simon. I hope I get a chance to meet all of you at some point, and once again, welcome you to this webinar. So I'll ask to advance to the first slide. So the first limb salvage attempt, historically, or so it seems, were these two twin brothers, Comus and Damien, who were apparently medical ministries in and around what Turkey is today. And they performed the first transplant. The guy laying on the bed there is a depiction of one of their avid parishioners who was dying from a cancer of that bone, and he finally sort of fell off into a coma. Nearby in the town, there was an Ethiopian, a Moor, who had recently died, and they amputated his leg at the appropriate location, transplanted it onto the parishioner who awoke, and the story goes that the miracle of the black leg survived. A lot of people at that time didn't think this was a good thing, and the twin brothers were martyred 287 AD. So we've sort of come to full circle. Next, please. So what does sarcoma, what's its etymology? Well, it's a fleshy growth, fish flesh. That's what it looks like, as you know. Sarcomas are not new. There's dinosaur bones a couple 100 million years ago that show osteosarcoma equivalents. Next, please. So what I'm going to do is go and list some of the orthopedic oncology seminal events in this timeline. And in this outline that I give, the top sort of heading discusses some medical major events at that time to put things in perspective. And then I've grouped some of the oncologic events in surgical, oncology, or radiology advancements, and then pathology. A couple dates. I'm not going to go through everything, but I'll start here with Edward Jenner giving the first live virus, a cowpox virus, to people to create the first vaccine in 1796. It was also the time around the turn of the century for the first human blood transfusion. In terms of sarcomas, Abernathy was first to describe what a sarcoma was only by its gross characteristics. Next, please. So a little bit about what Abernathy did. He did what we try and teach now, and that is look and correlate anatomic osteosarcomas or tumors with now radiologic and other characteristics to create an accurate picture. He didn't have quite all of those tools, but the thinking was the same. Next, please. So around the beginning of the Civil War was the introduction of ether as a anesthetic, important for surgery. And as the story goes, it's an interesting one that Crawford Long, of which one of the Emory hospitals was named after in Atlanta, first used ether as a surgical anesthetic in Georgia. But unfortunately, he didn't publish his results until 1849. William Morton in Boston at MGH performed a surgical anesthetic using ether and published his results a few years earlier in 1846. He gets all the credit for being the first true anesthesiologist. And if you ever go to MGH, there's a museum-like room that depicts that particular event with names and labels of everyone who was seated during that experiment. The British surgeon Lister published his antiseptic principles of surgery in 1867. There's a little caricature of what happened, and there's a little spritzer there that they squirted over the operative field. I think it was with carbolic acid or some sort of chemical. Virchow, once the microscope was discovered, began first bone tumor histopathology descriptions, also in 1867. Next, please. Post-Civil War, we have Koch, 1882, describing the one-on-one relationship between a specific bacteria and a specific disease, and Pasteur used an attenuated virus to create the first vaccine without a live virus. In terms of oncology, William Coley developed the Coley toxins, which was quite interesting, and especially Coley was a surgeon, and what he did was he heat sterilized different bacteria. Strep was the first, and he used it on a patient with Ewing sarcoma, as it turned out, and it shrunk the tumor. So it was the first use of not only an adjuvant therapy to treat a sarcoma, but it was the first stimulant of the host's immune system, and hence Coley is called the father of immunotherapy. Next, please. Well, Gluck was the first surgeon to use ivory to create the first ball and socket joint in 1891. Lexer, as now we're starting to understand more about sarcomas and how to treat them. Lexer in Germany was the first to use fresh osteoarticular allografts. I'm not quite sure how he harvested them or inserted them or what the infection rate was, but 1908 was certainly a early date for that. Remember that Rankin was the first to develop X-ray, 1895, and Edison a year later was the fluoroscope to begin imaging, both for surgical and other medical modalities and treatments. Next, please. So as we come into the 20th century, it was the first meeting of the College of Surgeons that took place in Chicago, 1910. Bloodgood at Hopkins started treating giant cell tumor. Now that we could separate some of the sarcomas and bone tumors from one another, he used phenol and some kind of bone chips. Codman described his epitomous Codman triangle, 1909, depicted here in this X-ray that I copied with the reference there, showing the periosteal elevation, the new bone formation as the tumor lifts the periosteum up off the diseased bone, 1909. Should also note that the Nobel Prize for vascular anastomosis was also first performed in 1912. Carroll was French, but he did all his training in Chicago and New York. Next, please. As we move to the time period between the Great Wars, antibiotics were discovered in 1928. The first metal hip replacement was performed in London by Philip Wiles. It was bolted and screwed to the host bone. Some surgical advancements. Borgrevi was the first to perform a rotation plasty, which I've depicted here in an adolescent. The rotation plasty at that time was used for tuberculosis. Later, Van Ness popularized the same procedure for bone tumors. Tiekoff-Limburg, Scandinavia, did a resection arthroplasty, also named after them. The Tiekoff-Limburg is a double resection arthroplasty where both sides of the joint are resected and it was left flail. 1940 was a major event. Dallas Phemister in Chicago began to study the normal biology of bone healing and the diseases that affect it. He described aseptic necrosis, subsequently known as osteonecrosis or avascular necrosis, and the famed and still apt description of how bone heals on itself by creeping substitution. He began a 6-year residency studying bone and other tumor pathologies and was the first person to begin a bone sarcoma registry. At that time, he was a member of the American College of Surgeons. He was actually nominated by Coley. Ewing's started his treatment, noticed that Ewing's was sensitive to radiation, 1919, and others started treating osteosarcoma in a variety of ways, aside from just amputation. That's the Kate Ferguson reference below. Next, please. So in 1953, Watson Crick discovered the double helix of DNA. And as we move closer to where we are today, George Hyatt developed the first tissue bank. It was in Bethesda. He was a Navy surgeon, an orthopedic surgeon. And this is the first tissue bank discovered and was sustainable. It was developed techniques for cryopreservation, sterile harvesting, how to maintain the bone in a usable state. Quite an advancement. Also, another advancement that you may not be aware of is Arthur Purdy Stout, 1953. So Stoutian pathology was notable for not just his study and chronicling human cancers, but essentially he started surgical pathology. So he would be in the operating room or near the operating room, would start the concept of frozen sections and margin review and characterization of the tumors. The first bone tumor Bible was Jaffe and Lichtenstein, 1958, from New York. Next, please. So 1960, the Charnley low friction total hip in London, polymethylmethacrylate and poly was used successfully. Here in the States, more and more aggressive surgery was being performed for bone sarcomas. Ralph Markov in New York started using liquid nitrogens for some of the benign aggressive tumors. And since there weren't prostheses and major implants that were successful at that time, allograft usage became proliferative. Frank Parrish in Houston used a lot of fresh frozen allografts. Otto Lengi in Buenos Aires, it's still quite popular in Buenos Aires with a lot of long-term follow-ups, and Volkov in Russia used a lot of allografts. So 1908 was Lexer, and then here we start to have the international usage of allografts to reconstruct bone deficits after limb salvage resections. Angiography and multi-institutional studies of sarcomas were beginning. Darlene at the Mayo Clinic published the second major Bible on bone tumor pathology. Interestingly, Lee and Fermini, two different medical geneticists, identified and published their genetic syndrome named after themselves. It wasn't until 10 years later that P53 was identified. 1960, also quite important. It was the first cytogenetic identification of a specific reciprocal translocation that was identifiable for chronic myelogenous leukemia, the so-called Philadelphia chromosome, which was a translocation between the 9 and the 22nd chromosome. We're going to see more of that as we move forward in time. Next, please. Well, the MSTS first founders meeting was in 1977. I'll go into that in more detail shortly. Major advancements for the treatment of osteosarcoma began in the 70s. Jerry Rosen and Ralph Markov in New York, and Norm Jaffe first in Boston, and then he moved to Houston, identified that high-dose methotrexate for adolescent osteosarcoma was important as an advancement in survival, the first major improvement in the overall treatment of osteosarcoma. Also, and importantly, Enneking did much of his work and published in 1977 his single institutional results describing the compartment theory for how tumors grow and thereby predict survival. This was field tested by the Musculoskeletal Tumor Society and shown to be accurate and is accurate still. Next, please. A tribute to Norm Jaffe, who along with surgical colleagues in Boston, Crawford Campbell, in specific, developed the current regimen of high-dose methotrexate. He was the first non-surgical member of the Musculoskeletal Tumor Society, Norm Jaffe. Next, please. So here's an interesting story of how neoadjuvant chemotherapy came to be. So it happened in New York, and in the 70s, Ralph Markov was a very aggressive surgeon at Memorial Sloan Kettering, and quite a reputation. I never knew him, even though I'm old, but he worked with Jerry Rosen, the medical oncologist at Memorial Sloan Kettering. And Ralph was saying, well, listen, I can cut out a distal femoral osteosarcoma, but what am I going to reconstruct it with? We really didn't like the use of allografts in that particular time and location. But right across the street at the Hospital for Special Surgery, whose initials HSS are actually my own, they had these two famous individuals, one John Insall, orthopedic surgeon, and the other Al Burstein, a PhD, and he was a bioengineer. And you know, they are responsible for the Insall-Burstein knee, the posterior stabilized total knee, which the design concept has become the standard for a total knee. So what Ralph and Jerry proposed to his bioengineers 4-minute walk away was, hey, listen, we'll do the biopsy, and how long will it take you to fabricate a custom distal femoral endoprosthesis with a total knee replacement so that I can insert it? And they said, oh, it'll take a couple months. So Jerry Rosen said, well, we're not going to let the child go untreated, so we'll give him the chemotherapy that we've now been working on, that Norm Jaffe based using high-dose methotrexate. So Jerry Rosen had a bunch, and many of his colleagues had a bunch of different protocols. They were T something or other, T5, T10, T12, all differing doses. And they would administer that, and after a couple cycles, the new custom-made endoprosthesis, the so-called MEGA, was fabricated. Ralph Markov put it in, and we have the beginning of neoadjuvant chemotherapy, which revolutionized cancer treatment, not just sarcoma treatment. Next, please. So a lot of institutions adopted that philosophy, and the graph I have listed for you in blue on the right is one institution, the Mayo Clinic's survival rates for osteosarcoma by decade, approximately by decade. So if you look at the lowest curve, the worst survival, over time, it was for in the pre-1960s, where the survival rate for osteosarcoma was 20%. They would die within a year or two of pulmonary metastases. And with each advancing decade, you can see that the survival rate increased and improved, especially as we move up to the 70s and the 1980s. Why is the question? Did the disease change its biological behavior, or were there other things that were causative for that? And that led to many questions, and the Musculoskeletal Tumor Society was instrumental in answering many of those questions. But the concept of neoadjuvant therapy rang true. It treated systemic disease, some of which was not imageable in the pre-MRI era, and where CTs were used. And before CTs, it was only bone scan and plain films. MRIs came around in the 80s. Use of the compartment theory, new implants, and the predictor of survival that chemo-induced tumor necrosis provided expanded our knowledge and improved our staging of osteosarcoma such that we were able to make a significant advance in the survival. And frankly, we haven't really changed that natural history of osteosarcoma since. Next, please. So just to go backwards just a little bit and talk about how mega endoprostheses were begun. The first was the Waldius, which was started first as acrylic in 1950s, and then late 1950s would become cobalt chrome. It was a hinged prosthesis, obviously had a lot of loosening problems. The hip was a lot easier to reconstruct. Austin Moore did that with his first endoprosthesis in the 40s. But then the endoprosthesis became metamorphosized from custom to the modular design, which is depicted in the central picture, a so-called double mega. And then we had the introduction of growing prosthesis, as many of the osteosarcoma patients still had a lot of skeletal growth remaining. So the first many series were invasive growing prosthesis, where you had to make a small incision and crank the prosthesis taller. The first design was by Stanmore, 1976. Then the Lewis expandable, the LEAP prosthesis around 1980 in Memphis. That design was improved upon by using the Phoenix and Rapiphysis models for growing prosthesis. The first non-invasive models around 1990. The picture to your right was taken from the article by Beebe there, and there was a lot of implant failures. I know that was the time when I started my practice. I wasn't putting any of those in. We were mostly biological reconstructions at that time. Finally, the new Stanmore design for non-invasive worked out the growing magnet beginning in 2004 and is now pretty much widely used across the world. Next, please. So in the 1980s, I talked about MRI era beginning. The Musculoskeletal Tumor Society started to develop functional outcomes scores, the limb salvage and ISOLs. The limb salvage group started to function and work on different implant designs. But I'd like to talk to you about the biological advancements as we started to learn about the genetics of sarcomas. The first major advancement was the identification of the reciprocal translocation for Ewing's, the 1122 translocation, here taken from a summary article, Turk Carell's first identification of this in 1983. You can see that the long chromosome is the 11, the short chromosome is the 22, and there's a fusion after the translocation where the 22 chromosome, the short one, becomes shorter, and the long chromosome, the 11, becomes longer. This is a FISH study of fluorescent in situ hybridization, each dot representing the new fusion gene in a Ewing's sample. Next, please. So this is a karyotype of a single cell in a Ewing sarcoma. There's a couple abnormalities. One is a trisomy of chromosome 8. You know, all the chromosomes are paired, but these are cytogenetic techniques that were popularized by Avery Sandberg and Julie Bridge, and they started to catalog all the genetic aberrations in bone tumors. And in this particular Ewing's, you can see in the short chromosome 22, the single chromosome that underwent translocation became shorter, and the 11 chromosome, where that bit from the Q arm or the long arm of the 22nd chromosome fused onto the 11, making it longer, and created the fusion gene, which created a protein product that was triggering the oncogenesis. The important thing to note is how normal this karyotype looks, and every cell in a Ewing's looks like one another, a so-called clonal tumor. Next, please. That's in striking contrast to this karyotype of a single cell of an osteosarcoma. So this is one cell in an osteosarcoma, and every cell looks completely different from one another. There's no single mutation responsible gene. As a matter of fact, the chromosomes are in many cases unidentifiable. Even the number of chromosomes per cell is different from one to another. Hence, there's never going to be a drug or a single treatment that can treat a non-clonal tumor like osteosarcoma, or frankly speaking, any solid tumor, but especially most sarcomas. And in contrast, I show you my karyotype, which looks amazingly normal. I know Ginger has seen my karyotype many times in the past in prior lectures, and I'm always proud to say that the chromosome, the Y chromosome, is well positioned. Yes. And functional. Okay, next. Well, the 1990s was the era of molecular diagnostics and the beginning of targeted chemotherapy. BRCA1 and 2 were identified for breast and ovarian cancer. And in terms of sarcoma treatment, Murray Brennan at Memorial started developing multi-modality therapy for soft tissue sarcomas. DBX, demineralized bone matrix, was started to use in bone reconstructions, utilizing the bone morphogenic protein, which was identified long ago, 1965, by Urist. IMRT, advanced conventional external beam or collimated radiation therapy. IMRT allows the radiation beams, the photons, to be bent and tailored to the particular tumor geometry such that organs of interest can be preserved and collateral damage minimized. The first antibody, monoclonal antibody, was approved in the United States for non-Hodgkin's lymphoma. Still used is rituximab. The other major clonal, not non-clonal, but clonal soft tissue sarcoma is the GIST, the gastrointestinal stromal tumor, had a single gain of function mutation at the KIT oncogene, which created its trigger for oncogenesis, and Gleevec is still used for its treatment. Next, please. So now the ancestry of the Musculoskeletal Tumor Society. Before its foundation in 1977, Phemister, his disciple in Chicago was Howard Hatcher. The Musculoskeletal Tumor Society fellowship grant is named in his honor. And Hatcher was an unusual person, but a great teacher. He's more known for his students than he is for his publications. I think he had one major publication on rickettsia. But he had an astounding cadre of successful academic orthopedic surgeons, many of whom became chairman and many of whom became champions of in orthopedic oncology. I've listed them for you. Glance at them: Akeson in San Diego, distributed across the United States; Miles in Colorado, Crawford Campbell in Boston, Bill Enneking in Florida, McCarroll, St. Louis, Bonfilio in Iowa, Gene Mindell in Buffalo, Tom Brower in Kentucky, Henry Mencken in Boston, Mary Sherman, Dallas, John Fahey in Chicago. I like to tell the story that I did my residency in Chicago, and I was doing a research project, and I was looking for some old records of some patients, and they gave me the key to some old subterranean freezer, which was no longer a freezer. God knows what they had saved in there. But I was looking through old logs and catalogs and files, and I came upon resident evaluations of prior residents and interns that had come through the program in Chicago. And I found two notable resident evaluations that you might find interesting. One was of Dr. Enneking, and the other was of Dr. Mencken. And I read them. Unfortunately, I didn't copy them, but I hasten to say that they were rather unremarkable. And I bet you everyone listening tonight, present company, at least the speaker excluded, your probably resumes and evaluations were far, far better than either Enneking's or Mencken's. So there's still hope for us all. That's all I could say. Next, please. Well, this was the first MSTS so-called founders meeting, May 5 and 6 in Boston, 1977. It was by invitation only. 16 people were invited. The hosts were Henry Mencken and Crawford Campbell. You'll notice that Norman Jaffe was there as well, also from Boston. Enneking wasn't there. He couldn't make that particular meeting, but made pretty much all the rest. Next, please. These are some of Dr. Simon's slides, the first historian, which he presented a couple years ago. Some of the early highlights within 10 years or so of the foundation. The first 10 years were very small meetings, usually just the founders and then a couple of fellows that they would bring along that were from their programs. The MSTS wasn't officially a organization until 1988, when bylaws and registries and certification within a state was performed. It was in Minnesota with the help of the Mayo Clinic founders, that being Doug Pritchard and Frank Sim. It was a very exclusive club to get into. It had very stringent requirements. You had to have at least 2 publications, none of which could be a case report. You had to show attendance for a couple years at various meetings, and you had to have excellent letters of recommendation. In those times, a membership committee and officers were formed. Next, please. The next 10 years or so, more and more fellows were educated and gone out into begin their practice, and major issues and debates that occurred on the floor discussions of pretty much every Musculoskeletal Tumor Society meeting were debates pro and con for fellowships. How many fellowships should be offered? How many graduates of musculoskeletal oncology should be trained to go out and practice? Should there be a certificate of added qualification as is used in general surgery? There was accreditation issues with the American Board of Orthopedic Surgery. And there were medical legal aspects of what was necessary for workforce, but also for free market issues. So it became quite a contentious issue in the 90s. Next, please. As the data accumulated for the use of neoadjuvant chemotherapy for osteosarcoma, particularly in the distal femur, questions arose. Were we actually helping patients or not? What was the local recurrence rate of limb salvage versus amputation? What was the overall 5-year survival rate? As you know, osteosarcoma is quite limited, and maybe 400 per year in the United States, maybe. How many were in the distal femur? How many were in adolescence? Not that many. So these are the major publications that resulted in the data that proved that amputation produced the same result as limb salvage in terms of 5-year overall survivorship and local recurrence rates. So Mike Link was a multi-institutional group. Simon published his article with the help of the Boston group and Henry Mencken, Jeff Eckhart in California, and Dempsey Springfield also in Florida. And the survival rate really hasn't changed, once again, at about 70% overall. Next, please. Well, the ancestry of who trained who and who were the original founders was first attempted in this caricature poster that was made by the flamboyant Dave Pitcher. He was an interesting individual, started in New Mexico, traveled about the United States, and had little vignettes and pictures of the various founders of our society. This is hard to read. I couldn't read it, so I tried to make my own little ancestry.com, which I've depicted here in the next slide. So these are the major programs that produced fellows. They were usually a higher volume in terms of sarcoma treatment, but describe the ancestry of our society. The first on the left in blue is the Boston program. Mencken was the first president of the Musculoskeletal Tumor Society. His first fellows I've depicted in the next generation line: Gary Freelander, Mike Joyce, Mark Gebhardt, and Bob Bell. Bob Bell went on to start the sarcoma program in Toronto. And as we move from left to right, the Mayo Clinic with Frank Sim and Doug Pritchard. One of their first fellow was Jeff Eckhart, started the UCLA program. MD Anderson in Houston. John Murray was one of the founders, and I think I have the third president of the society. The Gainesville group in Florida with Dr. Enneking and his fellows. John Makeley ended up at Cleveland. Jim Neff, who was actually married to Julie Bridge in Kansas City, and they started he supplied the tumors for her cytogenetic analyses. Mike Simon in Chicago, Dempsey Springfield in Florida, and Boston. Then you can see the Memorial Sloan Kettering group with Joe Lane and subsequent fellows who essentially stayed there, Pat Bolin and John Healy. In Italy, there was a lot of work with the founder of Mario Campanacci. There's many Campanaccis, most of which did their training at the famous Rizzoli Institute in Italy, and Rob Greimer, more of the second generation of fellows in England in 1984. There are many non-surgeons, non-orthopedic surgeons who were instrumental in the early contributions for our society. Steve Withrow, Fred, who was a veterinarian in Colorado, did a lot of histopathology and dog experimentations. You know, osteosarcoma is about 9 or 10 times dogs than it is in humans. Fred Albert, Murray Brennan, and Rafe Pollock were general surgeons who practiced a lot of soft tissue sarcoma work. Next, please. The next generation becomes even more complicated. I've put these two individuals as prototype examples. Myself, I had a residency from Mike Simon, a Gainesville founder, and did my fellowship at Mayo, so I have kind of a dual hybrid. We've developed our fellowship, likewise Chappie Conrad, now in Houston, but previously many decades at the University of Washington, had his residency in Florida and his fellowship in New York. Next, please. As we approach the end of the talk, some of the early history of the Tumor Society moving forward in time. We started around 2000 having industry sponsor our meetings. CORE became our official journal, publishing the oftentimes our symposium from our annual meetings. Gene Mindell was the deputy editor of CORE at that time, one of the Hatcher disciples, and he instituted that, and we started developing mission, vision, and goal statements for the society. Next, please. This is a membership histogram. It began with 16 members in 1977, grew slightly to 25. I don't have accurate numbers of the membership until it grew into 2013, when we got official and sustainable support through the Academy, which you are most familiar with, and membership has slowly grown. In between the years of 1980 and 2013, essentially the Tumor Society was run out of the president's office and their assistant. And these were voting memberships. There are several categories for being a member within the Tumor Society, but only active members and associate members had voting rights. Next, please. And then I believe the last slide is, I'm not sure where the original logo for the MSTS came from, but according to Dr. Simon, it began around 1980. And just this year, we voted on, at least the board did, and Michelle Gert being president, they decided that this is our new logo. So I hope you like it. And I think that's the end. Next. I'm happy to take comments, questions, or silence. I don't know which, but thank you very much for your attention, and I hope this proved informative for you. Thank you.
Thanks, Herb. If you guys will put any questions you have or comments in the chat. I don't think we have the ability to open this up for the participants to talk to you directly. Tell us if you want to put questions in. Tell us about Bill Inneking, Henry Mencken. You know, some of the people who are now deceased, but.
Well, I knew Dr. Enneking more than Mencken. Mencken I just knew from meetings. Bill Enneking was originally from Milwaukee, so that's how he got down to Chicago to become a Hatcherite. But I think his wife was from Middle Tennessee, so he had a connection to the South. What I remember most about Dr. Enneking, who was fiercely respected at meetings, as he would sit in the front row for all the meetings and wouldn't say a word until the last day, the last session. And, you know, in the years as I depicted, you know, the 80s and the 90s, we started having a lot of presentations by various groups about their various limb salvage techniques. And you know, this person would use this implant and this would another, and this would cemented, long stem, not long stem, so on and so forth. And he wouldn't say a word. There'd be usual question and answer. And then at the end, at the end of the meeting, he would stand up and say, listen, I've been recording what the actual complication rate was from all the presentations here, and I got a 50% complication rate, and none of you listed complications more than 10%. So what's going on here? Who's lying and who's telling the truth? That was the kind of guy he was. He was data-driven, very frank, very bold, but smart as a whip. And I never got to scrub with him, but I did teach his course one year, and I'm quite familiar with the program and the current orthopedic oncologists there. So he had quite an impression on many orthopedic oncologists.
Who do you think, you can name one or two people, who do you think are the most I don't want to say unappreciated, but like underrated orthopedic oncology people who've been in the MSTS?
That's a good question. You know, it's hard to assess a single individual's relative contribution to either the literature or the best surgeon or the number of trainees. I think that I put the most emphasis on someone like Hatcher or Femister or the great teachers that not only could instill the proper concept and patient care, but teach orthopedic oncologists how to think, how to make a diagnosis before you proceed, how to talk to your patients. And not just that, but those that were pioneers to bring that skill set to new areas of the country and the world. You know, many of the fellowships mentioned, especially Toronto and New York and probably many others, have many international fellows that have since left their fellowship and gone on to do great things in various parts of the world and various sectors of the United States that previously had no orthopedic oncology. So it'd be those people that brought it to the West Coast and to the mid-United States, I think, that I think are undervalued or at least not recognized for the contributions that they have made. I think that was a good answer, don't you, Ginger?
Fantastic. Fantastic, my lord. Julia is trying to ingratiate herself with a few questions I'm going to ignore because Paco wants to know if you could speak a little bit more about the CAQ debate in the 1990s and what went into the thought process to not pursue that with the academy or otherwise.
Well, it came down to legal issues. I think that was the main deterrent. I think kind of like things are today in politics, half the audience wanted to limit the number of trainees, and I use that term probably too liberally, and half did not. As I said, the incidence hasn't changed, and the argument was, well, to be a good academic orthopedic oncologist and advance the mission of the MSTS, which is education and advancement of our field, you have to see certain number of sarcomas per year. It can't be one a month. Maybe, I don't know what the magic number is. Is it 10 a month? Is it 8? But it's certainly not 1. So if the incidence of sarcoma hasn't changed over millennia, then how many orthopedic oncologists do we need in the United States, or per million population? And the data at that time was usually 1 orthopedic oncologist per million population. So certainly a large urban center would have more than a smaller city. So that was the argument in favor of limiting the number. And then there were various ways of limiting the number of graduates from oncologic fellowship programs. Another way to do it would be to have a fellowship meet certain criteria, not just to be ACGME, but to have a certificate of added qualifications. And they do. We used to have a big discussion with the American College of Surgeons in their general surgery oncology, who have CAQs for breast surgery and pancreas surgery and so on, and hepatobiliary. So that was another way to kind of limit it. But then, people would say, well, you can't, it's a free market capitalism. You can't control the market. And that's going to run it. Someone's going to challenge it. It's going to end up being a losing proposition. And we'll just have to suffer the consequences, if you will, of having perhaps too many fellowships. And in that scenario, it may be that we train too many people. It may be that the fellow is not being used to their potential and is used more for service than for educating, similar to a lot of residency issues in terms of program directors and guidance. So those were the issues that were debated frequently without a real solid endpoint answer.
Rafi, what's the current debate for fellowships and limiting, not limiting?
Yeah, I was just gonna, it's very interesting. It is kind of the same debates now. And ultimately, I think it's kind of the debate stalls out, because ultimately to do something like a CAQ is a very big hurdle. And we're not, you can argue either way about it, but I think it's the same debates we're having now versus later. I mean, versus earlier. How many fellowships do we need? What is the need of society? And also, I think in the U.S. is, where is that need? Do the major cities like Chicago, New York, Dallas, pick a major city, do they need more orthopedic oncologists, or do we need to have really good centers kind of where people can't travel 3 hours to get to a sarcoma center? So it's interesting. The same debates.
Dr. Schwartz, Julia asked, what's been the most valuable part of the MSTS for you?
I think over time, it's how little things have changed, to emphasize Rafi's point, not just in the political aspects, but frankly, aside from the technological advances in implants and imaging, I don't think we've made an impact since the introduction of high-dose methotrexate in the treatment of osteosarcoma. I think we've learned a lot more, but we have not impacted the survivorship of many of our sarcomas. And I think that is where we need to target. That is the issue of what we need to make advancements in. in the fellows that are listening now in their career lifetimes.
Can I add on to that? Actually, if you don't, I'm curious as well, maybe from Dr. Holt yourself, or even with some of our fellows, Dr. Schwartz, like, because that's one of the things that I think a lot about is like, what am I personally doing, and what are we doing in society that's any different now than it was, 2 years ago, 5 years ago, 10 years ago? What's the next kind of thing? I can kind of make maybe a little, a list of like, well, we're trying to minimize complications. We've got better, soft tissue techniques, et cetera, et cetera. But I'm wondering what, or bone regeneration, incorporating trauma techniques like Mascale, et cetera. I don't know what people on the chat here, like, what do you think things are like really cool that we're doing now that we didn't do maybe, or, as best as you understand, not 10 years ago? Ginger, what do you think?
Well, yeah, I would ask Herb. This, and this is one of the things I think is that this generation, the generation of fellows we have on, are way better than we have ever been about collaboration. And, I think Herb's era, technology, emails, cell phones, faxes, all those things not being available. You would see these
fire. You forgot to say fire. Yeah.
Fire. You would see these big silos of people presenting their research, their data. I remember sitting through the Tumor Society meeting and the same person kind of presenting the same thing. And I think that this generation is way better than we are at, from collaborative games and collaborative things. They are, Michelle Gert has tried to lead the drive, is very difficult. But I think that the collaboration to bring together the numbers, to bring together the resources, to bring together the tissue, to have tissue banks will be way better than what I remember seeing at meetings, truly from Dr. Schwartz's, that generation, the generation below. Again, some of that is technology and the inability to do. But I think, for a rare disease, if you don't come together, share numbers, share tissue, share things, that's the first thing you can do to improve, what you do. And I don't know, Herb, you can speak to what the history was of, people holding on to their data or holding on to what they had. And I don't think that's the same today.
Well, thank you for introducing that, and thanks for asking that question. So these are my personal opinions. So take that as you will. But I think there's two main issues. One is the one Ginger just brought up, and that is sharing or collaboration. I think that we have to be very careful about the formation of the new registry that's being promulgated by the Academy. I think there's a lot of great advantages to that. But once again, you have to be careful about the data. There's articles out there that sort of give differing answers to when the registry is probed with the same question. And it involves data input and the reliability of it. So, there's SEER, there's the National Cancer Registry, and now the new Academy Registry. So we have to compare the advantages and disadvantages of that versus large single or small multi-institutional registries. Not to say it's bad, but you just have to be specific about the endpoint and make sure it's a hard endpoint. And there's a lot of publication pressure. Now there's a proliferation of fellows coming out, and they're under pressure to publish. And sometimes by searching registries and mining, it's a good way to get publications, but I don't know if you're advancing the field. The second area, I think, what would be paradigm shift for treating sarcomas. I think the multimodality treatment for sarcomas is the way to go. For most sarcomas, practically all, surgery will never be eliminated. You have to cut the tumor out. But if we want to improve survivorship, as was just mentioned by the Moffitt group at our meeting in Clearwater Beach, I was extremely impressed with the Darwinian approach towards chemotherapy, neoadjuvant chemotherapy, for selecting subsets of various resistant tumor cells and sort of highlighting those and then cutting those out. And combining mathematical formulas, physics formulas, targeting specific targeted chemotherapy that can sub-select certain cells, and then we can cut them out. And I think it's those opportunities, those better understandings to better treat particular sarcomas, which will be our next survival advantage leap for our society. And it's going to be smart people like that help us and guide us. And what can we do? We can provide tumor for them, tumor banking and collaborative and collegial working together to get that kind of information, to provide that kind of data, whether it be in vitro first and then followed by in vivo. But I think it needs to start in that direction. My opinion.
Well, that's what we're listening to tonight, your opinion. So thank you. It's about 8:03, so we don't want to keep running over. Dr. Schwartz, thank you for this kickoff meeting as the MSTS historian. Your fellowship directors got an email today from the MSTS for the fellows to try to get you guys involved. If you haven't signed up to be a candidate member or be a part of the MSTS, log off now and look for that to do. Get your letters from your fellowship directors, get that in. So you can be a part of the society. So thank you again, Deborah, Carey. Thanks for throwing this together for us. Rafi from the fellowship committee, thank you so much. Dr. Schwartz, I owe you a bottle of bourbon. Thank you.
Thanks, guys.
Thanks. Good night. Appreciate it.
See you next time.
Right.